I wanted to introduce a very distinguished friend, David Albala. Dave has been in urology for many, many years. He's one of the most well-recognized faces in urology. He's actually much older than me. But I knew him growing up as a medical student, as a resident, and I read all of his papers because I trained in the field that he pioneered. And so Dave and I have become very good friends over the last decade and more, and pretty much every single conference I have had, he's been there to support us. So we really want to thank Dave and his wife Fran, who's back there. They've been a great supporter of us, and we're very close to the Albala family. David has been in many places. He was at the University of Chicago. He was professor there. Then he moved on to Duke University. And at Duke, he was a professor of urology. And there he pioneered robotic surgery program at Duke. And so the program that exists there is Dave's program. And he really made the innovations in robotic surgery at Duke. And so we've been working with robotics almost for a decade. Dave is now chief of urology at Krause Hospital in Syracuse, New York. And so once again, he's pioneering a new trail and taking care of healthcare in Syracuse. But I think what will be interesting is Dave's one of the experts on prostate cancer, and so he can answer almost any question you may have about PSA, recurrence, prostate cancer outcomes, and he'll also be around for some of the Q&As. And so I want you to welcome our friend David Albala.
Well, thanks, Vip. It's actually a real pleasure to come down. I think I've been to Celebration Hospital and Celebration, Florida, longer than I can, probably at least 20 times now, which if you have a 7-year-old is a great place to come. My wife and Jack go off to the park while I do all the work, and I think I've been to Disney once since I've been to those 20 times. But Vip and I go way back, and this year we tried to do something different with Dr. Patel. And you may not know this, he's an avid sport fan, and I've operated on some people in the NFL and was lucky enough to get Super Bowl tickets and have gone to a number of Super Bowls, and the people that we've taken care of have taken us on the field and to meet some of the players after the game. So I decided to bring Dr. Patel one year. Actually, I think he's gone twice now, if I'm not mistaken. One was in Miami, which was kind of his home turf, but when you compare Dr. Patel to a football player, usually the football players win, and they're athletic, but Dr. Patel has hidden athletic skills, and so this year we have a little place out in Colorado, and so we decided to take Dr. Patel skiing. Now, Dr. Patel grew up, his family's from India, and they're not sort of a kind of a skiing family, being from Florida. And I was actually very worried because I thought it might really damage our friendship because I'm an avid skier, and the kids, his kids and my son loved to ski and play together, and it was perfect, but I was worried about his wife and Dr. Patel skiing, and we took him over to Snowmass and out in Aspen, but unfortunately I forgot the slide of Dr. Patel skiing. But it was, but I will, hopefully if we do this next year, I will bring pictures and video of Dr. Patel going down a hill. I'm going to try and take him down some black runs next year instead of just the green runs that he's trying on. But we've had a wonderful time over the years, and just one thing I want to say before I start my talk is this past last week I was in Washington, D.C., and for some of you that don't know, I was a White House fellow for a year where I worked in the White House. I took a year off from medicine and worked for a cabinet secretary for a year. And the American Urological Association, the group that we belong to, is doing a lot of things on Capitol Hill, lobbying, and there's a couple of bills that are in Congress right now, and one of them is the Prostate Cancer Act. And this is an important bill because it's going to redirect funding, allow the Department of Defense, HHS, and a number of groups to funnel money into prostate cancer and prostate cancer research. And so all of you have a voice, and while I was up there, we went up to Capitol Hill and met some of the sponsors, some of the senators, and one of the things that's important is, as Vip talked about, is the PSA argument. And I think many of you know about this argument. I met the head of the task force, and we actually talked for about an hour about this PSA recommendation because it doesn't seem to make sense on why you'd get rid of a relatively inexpensive test for prostate cancer. And what's interesting is this task force is made up of a group of physicians that are family practitioners and biostatisticians and everyone but a urologist or an oncologist or a radiation therapist. So none of the people that are on that task force actually treat prostate cancer. They've read, essentially the recommendations were based on 2 articles that were talked about a little bit earlier, the screening articles. But I think as a group, we need to stand up, just like what the women did with mammograms. We need to stand up against this recommendation because I think it's a very bad thing that's going to happen. And a lot of senators and congresspeople are aware of that. And you, as a group of patients, have a very powerful voice. So I encourage you to get active and work with the congresspeople. This recommendation, I think, will have a significant impact. So with that aside, we're going to talk a little bit about PSA recurrence. And you might say, if I have surgery or I get treated with radiation therapy, how can I have prostate cancer that recurs? What is it? If you take the prostate out, it's gone. Well, that's true, but I'm going to show you what are important factors that you need to understand on why the PSA can recur and why you can develop prostate cancer recurrence. How many patients in the audience here are new patients that have not been treated? So there's a couple. Most, I would think, are the majority of patients that have been treated with one form of therapy or another. And we'll talk about surgery and radiation in just a second. So here's what we're going to cover. We're going to talk about what does a rising PSA mean to an individual? What does it mean when we talk about local versus metastatic disease or disease that's spread into the bones? We're going to talk about a rising PSA after radical prostatectomy and a rising PSA after radiation therapy. And those are the big sort of subjects that I want to try to cover in the next 13 minutes. Although, here's a guy right here, sitting right here in the front with the big, timer. I'm not going to look at him. I'm going to look at you guys instead. So, what does a rising PSA mean? Well, usually a rising PSA after some form of therapy means recurrent prostate cancer. And you might say, geez, well, I had my surgery done. They said all the cancer was contained within the prostate, but all of a sudden my PSA is rising. Well, there's a couple of things that can happen. There are some benign prostatic glands that are right at the level of the bladder neck that can account for a rising PSA. When we come through, if this is the prostate and this is the bladder, when we divide that line, sometimes there may be some prostatic glands still on the bladder neck, and that can cause a slight rise in the PSA. And that can cause a late PSA failure. But for the most part, if you see a rising PSA after surgery or after radiation therapy, typically you've developed a recurrence, and you can develop a microscopic recurrence. Even though we say that all the prostate tissue that had cancer is removed, there may be some microscopic glands that we can't see with the naked eye that remain, and if that's the case, then you can see a rising PSA. The PSA is a terrific test, especially in men that have had surgery. After surgery, the PSA should be 0. And if it's not 0, there's something going on. And you can see the median time for PSA recurrence after radical prostatectomy to prostate cancer death typically exceeds 16 years. So it's as we know, a very slow-growing tumor There are some men that will die within a year, but that's the exception rather than the rule. So the PSA is going to be our marker that we need to take home and remember. If you have an early rise in the PSA, typically less than 1 year after surgery, these patients may typically have metastasis. There are some rare exceptions. You know, when I was at Duke, there were a couple of patients that had very minimal disease that we operated on, and all of a sudden their PSAs never normalized. And all the margins were negative, everything looked very positive, but I couldn't understand why their PSAs were still relatively elevated. And there is some cross-reactivity with some of the antigens in the bodies and the antibodies that can cause the PSA to be abnormal. And the physicians that operate on you, like Dr. Patel, if that's the case, he may send off and do a separate type of PSA testing to rule out that. But typically, if you see an early rise, less than a year, there is typically spread of the prostate cancer. If you have a late rise, typically you see local recurrence. In other words, the prostate cancer spreads just locally out within the confines of the prostate. So we like to give the patient the benefit of the doubt when we talk to them. And what are the determinants of a rising PSA? Well, we're going to talk a little bit about how important the pathology is. You know, what are the clinical examinations that we can do as clinicians? And then what radiographic studies can we do to try to understand where the disease is? And you'll see that medicine is not very scientific in some ways, that the radiographic examinations really are quite poor indicators of recurrent prostate cancer. Well, one thing that all of you that have had surgery, one of the things that I'm sure your surgeon talked to you with is whether the margins or the margins of the prostate are negative or positive. If you have a positive surgical margin, I'll show you the data that indicates, depending on whether they're focal, just in a small amount of recurrent positive margin, or extensive. If you have an extensive area of cancer at the margin, that will have a significant impact on survival, and more likely those patients probably will require some type of additional therapy. If you have disease that's outside the prostate, extraprostatic extension, think of the prostate as an orange. And when we do the surgery, we take not only the juicy bits of the orange out, but the orange peel. And if that disease extends through the orange peel, that's extraprostatic extension, and those patients have a higher risk of recurrence and don't do quite as well. And then the last thing is the seminal vesicles. Those are these organs that stand behind the prostate. When we do your radical prostatectomy, we take out the seminal vesicles, and we look to see if there's cancer invading that. And if those patients have seminal vesicle involvement, typically those patients should get radiated and get hormonal therapy for at least 2 years. And we'll show you some of the data in just a second of all of these. But I want to kind of, it's easy talking to physicians because they know a lot of the terms. I want to level the playing field for all of you, because many of you may not be up to date with some of the definitions that we use. T2 prostate cancer is prostate cancer that you can either palpate with a rectal exam or is visible, on an ultrasound when we do your biopsy. T2A is prostate cancer that's confined to just one lobe. It's a half of a lobe. T2B is greater than half of one lobe. And T2C is when you have cancer in both sides of the prostate. That is what we call early localized prostate cancer. Locally advanced prostate cancer is a little bit different. And that's where you have spread beyond the prostate. And typically, if it's on one side, that's T3A, two sides, T3B, and obviously if you have seminal vesicle involvement, or if it involves one or both of the seminal vesicles, that's what we call T3C. So that just gives you T2 is going to have a much better prognosis because there's less disease than T3. That's the takeaway message. So I'm going to show you some curves, and I hate to bore you with this, but I think the curves give you a visual impression of what happens in patients, and this is groups of patients that have either T2 disease or T3 disease, and what we can expect looking out at these patients. Now, I caution you that every patient is different, Every patient, you're an individual patient, and you may not fit on one of these curves, but a lot of the data that we do and look at is putting these groups of information together. But here you can see the patients that have very small amount of cancer, if you look at disease-free survival, do very well compared to those patients that have seminal vesicle involvement. So I think you can look at the colors and you can see, if you just have disease that's contained within the prostate, those patients do much better than disease that's outside the prostate or in the seminal vesicles. Is that pretty clear so far? So we're going to just look at margin status. Now the question is ideally, when we take the prostate out, we want to make sure that the margins are negative. We can't always control that because the disease controls that a little bit, but also the skill of the surgeon can control that as well. If you cut too closely to the prostate, you may get a positive margin. You can see that patients that have negative margins, it would make sense they're going to do better than those that have a positive margin or disease. And what we mean by a positive margin is when the prostate comes out, we dip it in a bucket of ink and then we section it up. And the pathologist looks under the microscope, and if he sees cancer cells right at the cut edge, you have to assume that there's tumor that was left behind. In other words, if tumor is here and I cut right in the middle of it, I'm going to have, at the cut edge of the specimen that I look at, there's going to be cancer cells, and you have to assume that there's cancer cells that have been left behind. So here you can see those patients, if you look at cancer by margin type, those patients that have just focal or a very small amount of a positive margin do much better than those that have extensive disease at the margin. Again, if you look at T2 disease, looking at positive margin and negative margin, the black line is the negative margin. Those patients are going to do well. So the goal of surgery, and I think the major goal of any prostate cancer surgery, is to essentially get you cancer-free and give you negative margins. When I have patients come in, my 47-year-old neighbor, came in and said to me, I got diagnosed with prostate cancer, strong family history, and I went through, doing a robotic prostatectomy with him, and I said, there are certain things. The first goal is to cure the cancer. I think second is probably incontinence, and then third is erections. I said, Glenn, what's important to you? Erections are number one. What's second most? Erections are number two. What's third most? Erections are number three. The big picture is erections are important. There's half the room is guys, and if you took a poll, erections would be kind of important. But I think being around and living is more important than having an erection. Because we can give you an erection. We got lots of tools. We got, pumps. We've got injections. We even got prosthesis. The wives actually really like the prosthesis the best. But the bottom line is we got to get you cancer-free. And if we don't get you cancer-free, that's a problem. Now here, look at the curve here. These are patients that have disease outside the prostate. In other words, the disease has grown through the orange peel. And you can see, if you compare it to the disease that's contained within the prostate, these guys are going to do much better than the patients that have disease outside the prostate. And again, looking at, subcategorizing patients that have disease contained in the prostate, if you just have a focal margin versus those patients that have extensive positive margins, they're going to do much, much better. So, putting it all together, when I was at Duke, we had a very large prostate cancer center, and we had a lot of patients that we entered, and we started to do a hazard model, and that's looking at what are the most important factors, at preventing, getting the disease contained. So, if you take one and set that as the bar, every patient that has disease contained within the prostate gets a score of 1. What's the hazard or what's the risk of a patient that has just a lesion that's outside the prostate in one area versus two areas versus the seminal vesicles? And I think you can see that obviously patients that have disease in the seminal vesicles are not going to do as well as those patients that have disease contained. And again, when you look at focal positive margins compared to extensive margins, Those patients that have just a small amount of area compared to a large area of a margin are going to do much better. Now remember that patients that have a positive margin, they're going to be picked up or detected primarily with the PSA test. That is where PSA testing is, there's no question in the data that is a critical time to those patients that have surgery need to be followed with PSA testing on a regular basis. So, what about the clinical exam? Well, you know, I got yelled at Duke when I first got down there by a patient of Dr. Paulson's. He had done a perineal prostatectomy, and for those of you that don't know what that operation is, it's where you put a patient up in stirrups and you make an incision above the rectum but below the scrotum. So if this is the prostate, a radical prostatectomy, you're coming from above. A robotic prostatectomy, you're coming from above. But a perineal prostatectomy, you're coming essentially straight onto the prostate. And what's nice about that operation, if you've had multiple surgeries in your belly or you're very obese, you know, 400, 500-pound, you know, North Carolina linebackers and defensive ends, those type of patients that are very large do incredibly well with a perineal prostatectomy. But what's interesting is this one patient had a perineal prostatectomy. He was very thin. He was a normal-sized man. And Dr. Paulson had always come in and done a rectal exam on him. So when I started at Duke, I came in and saw the patient, and I said, your PSA's been undetectable now for 9 years. Things are perfect. We don't need to do anything more. We'll see you back in a year. He wrote a big letter to the vice chancellor at Duke saying how I was a terrible physician and I hadn't done a rectal exam on him. Now, he's the only guy that I've ever encountered that really wanted a rectal exam, but he really did. And the bottom line is, you know, the newer data has suggested that if your PSA is 0, the finger is not going to detect anything further. And indeed, the rectal exam is rarely normal in patients that have a rising PSA. If I saw a patient that did have a rising PSA, I'd take a feel, but I'm going to expect probably not to see anything. So you might say, well, if the PSA is rising, why don't we biopsy that area? Maybe we'll find the cancer. And the bottom line is it's very unreliable. And this is a study that we did at Duke. 20 men had recurrent prostate cancer. 8 out of the 20 had a positive biopsy, but all 20 of those patients responded to radiation therapy. So the rectal exam is relatively unreliable. The CT scan. Some of you might have had CT scans done or MRIs or bone scans. These tests are even worse than the rectal exam. They're not worthwhile, they're very costly, and the bone scan is really, I think, a test that's overused by many urologists. If the PSA is not greater than 40, typically the bone scan's not going to show anything, any type of activity. So we don't have a good radiological test. So that PSA test, again, is very, very sensitive. So how do we treat patients that have a rising PSA? And the mainstay of therapy is primarily radiation therapy. And we like to treat patients earlier rather than later. Clearly, the data suggests that if you treat patients before their PSA is greater than 1 after surgery, they are going to do better than those patients that are treated after their PSA is 1. And here are some of the data, and it may not project well. I don't know why the white lines. You can see that patients on the upper line were treated with radiation therapy versus the lower line, and you can see that at 10 years, 71% of patients are essentially metastasis-free compared to 61% of patients that had a rising PSA that were treated with radiation therapy. If we look at survival, again, you can see 74% of patients treated with radiation therapy that had a recurrent PSA tend to do better than those patients that don't receive radiation therapy. So I think the take-home message is that if you start to see a PSA recurrence, one of the mainstays of treatment is going to be radiation therapy, and you probably should get treated before your PSA gets up to the level of 1.0. So, but with any type of treatment, there are risks. And one of the risks after radiation therapy are listed here. This is from a big slide from a big study that was done by a radiation therapist in 2005. And you can see diarrhea frequency. Whenever you radiate the prostate or the prostatic bed, you can't just radiate the tissue where that prostate was or where the prostate is. You also radiate the rectum. That gives you the diarrhea. You also radiate the bladder. That gives you the hematuria or blood in the urine. So there are side effects that can occur with radiation therapy. And if you actually look at these curves, this is from the BOLA study that was published in Lancet, you can see that a lot of patients develop some form of complication, whether it's diarrhea. Most of these complications are relatively mild across the board. What is one way that we can try to look at PSA and help us to suggest, does a patient have aggressive disease or not? And the doubling time of the PSA is extremely important. And this is really a marker that we've now begun to use relatively routinely to predict what the response of radiation therapy is after patients that have surgery. So this is a study that was published by Ward looking at 211 patients. You can see that the PSA was greater than 0.2 in all of these patients that were entered into the study. And what they did is they looked at the PSA doubling time. And the doubling time was trying to give us an indication of how these patients were going to do, whether they developed metastasis or they survived. And the bottom line is the patients that have a short doubling time, less than a year, those patients are going to do much worse than those patients that have a PSA doubling time of greater than a year. If you look at the 5-year disease-free survival, if the doubling time is greater than a year, those patients have a much better prognosis than if the PSA doubling time is less than a year. So the doubling time is now an indicator in which your surgeon and your physician can use to try to predict the aggressiveness of the tumor. So when you go in to see the radiation oncologist, what we do is we treat the entire prostate bed, and the typical dose is 65 gray, which is about an average dose for an individual that gets treated. Well, this is just some data that we put together when I was at Duke. We had over 5,000 radical prostatectomy patients. These are patients that not only had robotic surgery, but also had open surgery, a retropubic prostatectomy, and a perineal prostatectomy. I'm one of the rare surgeons, I think, that can do prostate surgery 4 ways. I learned how to do them retropubically, perineally, laparoscopically. I went over to France. And then when I first started, actually Dr. Patel was one of the guys that I looked to actually even help me get better as a surgeon. And maybe that's, bounded our friendship, because now all we do is robotic prostatectomies. But there's some of us that are older and better looking than Dr. Patel that know how to do these older operations. But you can see we put together, a pretty good database. We had 408 patients that had a greater than 40% chance of developing a PSA failure. And we followed these patients for a couple of years, and you can see that the patients that had a biochemical failure or recurrent PSA did not do as well as the patients over here. And when you look at this in hard numbers, interestingly enough, only 14 patients died of prostate cancer in that 2-year period. Now, it takes much longer. I think if we followed those patients out a longer period of time, we'd probably have more deaths. But the bottom line is that this is a slow-growing tumor. The PSA is a useful marker, and that doubling time is extremely important for us. What happens after radiation therapy? Has anyone in the audience received radiation therapy? So there are a couple. Well, the PSA is a little bit different after radiation therapy. When you radiate the prostate, it takes a while for the PSA to come down and normalize. And what it is when you radiate the prostate swells, it develops inflammation. So a couple of groups, the Astro and Phoenix, are definitions for relapse. These are medical groups that have looked at recurrences that specifically look at radiation therapy patients. It's a little bit different because identifying those patients, you get a bump in the PSA after radiation therapy, and that bump can actually last for 2 years. And so it's a little bit difficult to try to compare surgical patients with radiation patients. We do know the bottom line is that PSA is a useful marker, but it may take 2 years to get things understood. So when we treat patients after radiation therapy that have a rising PSA, we treat them earlier rather than later. We like to see the PSA less than 2. And indeed, radiation does not make someone who's a bad surgical candidate a good surgical candidate. And that's an extremely important point because, you know, when you take a rectal exam and if you feel that the disease is outside the prostate, those more likely than not, what you're feeling is actually true, is that the disease probably is outside the prostate. And indeed, you know, as we'll see, the patients that fail radiation therapy, the limited treatment options that are available really fall into 3 categories. Either you can have a radical prostatectomy or a robotic prostatectomy. We'll talk a little bit about that. You can freeze the prostate, or you can put seeds in. Now, salvage prostatectomy or doing prostate cancer surgery after radiation is extremely difficult. I know Dr. Patel has done them, but I can tell you the biggest problem with operating after you've been radiated is that a lot of these patients are incontinent, they're impotent, and the risk of a rectal injury is extremely high. It's like putting a chocolate bar on a dashboard living in Arizona. You know, and you go out shopping and you come back, you know, it's still chocolate, but it doesn't look like the Hershey bar that you put there before you went out shopping. And when you look at some of the data, you can see that from Memorial Sloan Kettering in New York, 65 out of 146 patients failed, and the mean time to recurrence is about 3 years or so. If you look at Wayne State University data, 40 patients, almost 50% of patients failed, and the bottom line is that patients don't do very well. One other treatment after failure of radiation therapy is to freeze the prostate, cryotherapy, and you can see that disease-free survival at 5 years was about 60%. You know, the biggest problem with freezing the prostate is the risk of developing a rectal injury and having a colostomy or a fistula. That's the biggest risk whenever we see this. So I'm going to just stop. The last slide I have here, the best time for cure is the primary treatment. So when you are diagnosed with prostate cancer, you need to make a choice whether you're going to have surgery or radiation. And once you make that choice, don't look back. Salvage treatment after surgery is much easier is easier than after radiation therapy. In other words, if you develop a rising PSA, you can go back and radiate the prostate bed. If you radiate the patient first and they develop a recurrence, you can do a salvage prostatectomy, but the incontinence and impotence rates are quite high. And the best predictors of salvage success is if a patient had been a good candidate before primary treatment and is still a good candidate. In other words, patients that are going to do well, your best shot is right out of the blocks. I just want to thank Dr. Patel and thank you for putting up with me, and I look forward to your questions later. Thanks, Vip.